Hello, good afternoon, dear colleagues. I'm happy to welcome Professor Valentin Schäfer from my neighborhood, from University of Bonn, who is specialist in rheumatology, head of the rheumatology unit at the University Hospital in Bonn. And um, as me, we both are very interested in imaging in rheumatology and do that for several years. And so I'm very happy that he has prepared all what we have to know about imaging in a very, very rare rheumatic disease, imaging in relapsing polychondritis. We are happy to follow you, Valentin.
Yeah, thank you, Oliver, for the kind introduction. And thanks also for the organizing committee for giving me the opportunity to dive into this part of relapsing chondritis where I have not deeply been involved in. So thanks for the opportunity. My slides should move forward now. These are my disclosures. We have several working groups in my department which focus on 3D printing, for example, as disease in medical education and disease simulation. We recently published a high-resolution phantom for diagnosing giant cell arteritis within the OMARAC group. We have a Center for Interdisciplinary Ultrasound Research and Education, which is very active. We have a vasculitis research group, a group with artificial intelligence in rheumatology, where a professor is also affiliated who works only in artificial intelligence. We have a translational rheumatology group and a group focused mainly on pulmonary involvement in autoimmune diseases. This is my current working group with 2 PhD, 2 postdocs, and several scholarships. Further, we have 3 interdisciplinary centers here in Bonn, which I founded the Center for Psoriatic Arthritis, the Center for Uveitis, and the Center for Vasculitis West here at the University Hospital in Bonn. When we come to relapsing polychondritis, as you might probably know, we have quite a lot of clinical manifestations. You all know, of course, it's nasal and auricular chondritis, which is very common, but patients may also suffer of peristernal chondritis, a tracheal chondritis, articular manifestations in the form of arthritis, or even an involvement of the eggshell of the spine. Cutaneous involvement is not too rare. We have cardiac involvement with different parts, pericarditis, myocarditis, aortitis, ocular involvement, and also involvement of the audiovestibular system, as well as neurological manifestations and renal involvement. So what of these manifestations can we actually image? And those are some. We can see all, of course, the nasal auricular chondritis. We can see the articular manifestations, the involvement of the spine, and the cardiac involvement. And this can be imaged by the modalities you see here on the right side, meaning musculoskeletal ultrasound or ultrasound in general, MRI, and computed tomography. Let's start with auricular involvement. There has been at least some studies which focused on auricular involvement and correlated the degree of auricular involvement to histopathological findings and inflammatory cell infiltration of the innate immune system, but also of the adaptive immune system. And in this publication, very nicely, they also performed a PET-CT and found also an uptake in the classical FDG PET-CT alongside the ears. Well, I don't know if we need PET-CT to show chondritis of the ear. I don't think so. I also don't think that we need histology. We might need it in certain cases where we are really not sure if this is auricular involvement in polychondritis or any other form of inflammatory or infectious disease of the ear. But I certainly think that ultrasound might be very helpful. I would not put myself in the PET-CT unless we would really like to screen for more manifestations of polychondritis of the ear. In the same publication, the authors show several images also correlating with raised and normal CRP values here in a patient who has been treated. You see in the beginning, the ear is rather swollen, CRP level is high, ESR as well, serum amyloid is high, and then they treat the patient here, in this case with methotrexate and prednisolone, and we see CRP normalizes, acute phase reactance as well, and ultrasound correlates greatly because here we still see a hyperperfusion and power Doppler, which is a specific form of Doppler where we see a rather slow flow, and we see in follow-up the hyperperfusion of the ear is completely gone, and the swelling around the cartilage is also gone. So a very nice illustration here. And another patient also of the paper also treated over the time. And in these patients, we even see a further decrease of the swelling around the ear after the follow-up here several months under treatment. So really looking at the ear clinically can be very helpful, but in unclear cases, I think it's really worthy. Just put an ultrasound probe on the ear. It goes very fast. It's very easy to do. I'll show you a tutorial later. And then you know if there is still inflammation or not. And our patient is happy because he does not have to wait for an MRI appointment or a CT appointment, which is anyway not suitable to show the cartilage of the ear. Yeah. And what the authors have shown, and I like this translational aspect of imaging, that they really correlated the ultrasound activity to the immune cell infiltrates in the tissue around the cartilage of the ear. I don't think this is necessary. However, from a scientific point, of course, this is very interesting, as it really shows that imaging correlates with histological findings. Joint involvement, I named it before, of course, it's an arthritis. Like in this patient, it's arthritis of the wrist, where you see in longitudinal section, we have a hyperperfusion. We have only here limited effusion along the joint. It is rather a synovial hyperproliferation. And we see here the power toughness Doppler signals as a sign of synovitis here of the wrist in a patient. This, of course, is only used in unclear cases. We diagnose a synovitis normally in a clinical setting by doing just physical examination in unclear cases, where here, for example, where it's only little joint effusion, but really massive hyperperfusion in this form of arthritis, it can be really helpful. Pericarditis. I mean, how can it be diagnosed? Well, very easily by ultrasound. If you just put the abdominal ultrasound probe towards the sternum and you image the ear, and in this case here, you see there is a pericardial effusion around the heart. So this is a form of pericarditis in a patient with relapsing polychondritis and first diagnosis. And here comes the instructional video, which I made together with GE, why I was also invited, by the way, to give this talk. So I'll let you listen to it.
Valentin, you could not hear you speak at the video, so you have to comment it.
Ah, okay. That's very sad. I will try to comment it then. I was hoping it would be audible. So basically, I talk how important the sonography of the ear is, and that it is, of course, very easy accessible for ultrasound. What you need, of course, is the best ultrasound probe with about 15 megahertz. You might also use, of course, probes with less or with higher frequencies. Higher frequency is always nicer. And then you just put it on the ear. And here you see the cartilage basically shown on the cursor of the ultrasound image, surrounded by the soft tissue, which in this phantom or in this model is not inflamed. And then I describe the findings which we see in active auricular involvement, which you see here. So there is edematous change around the ear, the cartilage is thickened, and we see hyperperfusion in power Doppler ultrasound here in a patient with active polychondritis. I'm sorry that the sound was not transmitted. Another organ manifestation which we can image is pulmonary involvement. And we might see, like this, for example, is an image of a patient of mine where we see pulmonary involvement in relapsing polychondritis. This patient did suffer of a cough, which persisted although the patient received inhalative corticosteroids. Then we made a CT imaging, which has a very low radiation these days. So it makes really sense to do a CT and not a conventional X-ray of the chest. I think also the conventional X-ray of the chest will die very soon, and we then see these pulmonary infiltrates, which might be present in relapsing polychondritis. We can also image, of course, the arthritis by MRI, which is not commonly done because ultrasound is much more easy. Of course, what we gain is insight into the bone. As we know, we can only image with ultrasound all the soft tissues and the synovium until the bony surface, but we cannot go below the bony surface. And here this image shows very nicely the involvement of arthritis also of the bone, where we see really edema near the joint, which is another sign of arthritis and can be very helpful. Of course, we see also the synovitis, the thickening of the synovium, but really the advantage of MRI is that we see the involvement of the bone also. Actual disease, I mean, we can have actual disease, like I said before, and looks very similar than as spondyloarthritis. But of course, spondyloarthritis usually does not show an involvement of cartilage, as in this patient, for example. And here you see the same signs. So here, for example, shiny corners and spondyloarthritis in a patient with spondyloarthritis and polychondritis, or actual disease in polychondritis. Peristernal chondritis has been also proven or was just also listed among the clinical manifestations a patient can have. And here is a very nice publication. I don't have own images, where you see an involvement of the sternum in polychondritis with really increased soft tissue shadowing and very nice involvement here visualized by MRI. Unfortunately, I did not find any image because it should be also visible in ultrasound actually, but definitely it is visible in MRI very easily and shows also the involvement of the bone in chondritis. Pericarditis is also shown in MRI very nicely. If you are not sure, you sometimes might have in the early phase of pericarditis only little effusion. In a later phase, it will be much bigger. And here's a publication which showed the pericarditis in relapsing polychondritis with just an increased contrast here around the heart. Yes, and this was my short talk on imaging in relapsing polychondritis. I hope you enjoyed it. Many greetings from Bonn, Germany, and I'm happy to answer any questions.
Thank you, Valentin. Up to now, we don't have any questions. One question is to search for involvement, or should we arrange the imaging more depending on the clinical symptoms? What do you think?
I was waiting for this question. This is a very complicated question to answer, of course. Yeah, I think we should screen our patients when we make the first diagnosis of the disease. We standardly screen for lung disease because we have an ultra low dose CT established here, which has only 0.25 millisieverts in radiation. I think it is very low, so we just do a CT scan, and then we also know what's going on with the heart. If there's pericardial effusion, if the patient does not report of any dyspnea, we usually do not perform an echocardiography. And otherwise, we do a physical examination. We check for involvement of the joints. We check for any other disease manifestation we can see clinically. There are some authors which, like we know in any other rheumatic diseases, say, oh, let's look for inflammation in the whole body, and we perform a FDG PET-CT. I think, of course, this is a nice imaging modality. We work very much on molecular imaging parameters within the last years. But of course, it is a lot of radiation. Yeah, if we look at our low dose CT with 0.25 millisievert, and we have a PET CT with 10 to 14 millisievert, so I don't think it makes really sense to do this high radiation imaging in every patient. In some patients with high CRP levels, or in patients who have other respiratory symptoms where we are not clear if the involvement of the body is more severe or more extensive, it might really be helpful to do it, but I would not do it in general.
There's a question from Maurizio Cutolo, who asked whether you have any experience with the intervertebral disc as manifestation, because it's some sort of cartilage, and is it more the spondylitis, or is it just transferred?
Well, thanks again to the organizers giving me the opportunity to deep dive into this imaging and polychondritis matter. In my literature research, I had actually quite troubles even to find case reports in journals which are PubMed listed concerning the involvement of the spine. And in the case reports I looked at, it was most commonly very similar to spondyloarthritis rather than involvement of the vertebral disc. I asked also myself in preparation of this talk if the intervertebral disc could be involved. I think it could be. However, I did not find any proof in the literature that this was the case, and I have never seen it in a patient, which does not say a lot because I think we have a total of 16 patients with relapsing polychondritis, which is a lot, of course, but it's still a low number, right?
Okay, there's a question on a very hot topic, and that's imaging of the lung, because tracheal involvement is one of the major problems and one of the life-threatening problems. And it's asked that it's often advised to recommend a dynamic CT scan of the trachea within an expiration to see whether there might be air trapping or an involution of the trachea. First.
This can be very useful. It most commonly manifests in later stages of the disease. Also, sometimes if it was not diagnosed early, then there's of course also a damage of the trachea, and it becomes very collective. And in these cases, it can be very useful to do these dynamic CT scans under inspiration and expiration to diagnose it. In first diagnosis, we have done it in some patients, and we did not see an abnormality. We rather observed it in the patients who have been suffering for a longer time of the disease, at least were symptomatic for a longer time of the disease. But I don't know what your experience is, but in really patients with a short history of relapsing polychondritis, we never saw a collaptic trachea in dynamic CT scans.
One possibility to look at is the tracheal involvement without the posterior part, which is typical for the relapsing polychondritis, and differentiates it from granulomatosis with polyangiitis, which both affect the trachea. Sometimes you have a first involvement there and have problems to distinguish. There is a request according to your ultrasound imaging. The listener, Beba Naviera, understood that MRT or CT does not perform on ear chondritis, but only ultrasound makes sense. Trying to understand what makes sense to confirm relapsing polychondritis diagnosed beyond the visual manifestations.
Sure. That's a great question. I think we are clinicians, and I think really inspection and physical examination is very helpful. But to rule out other conditions, especially affecting or especially concerning the auricular manifestations, I think ultrasound can be really helpful, because we can see if there's some kind of infection going on, if we see an abscess formation, or if this is a diffuse inflammation affecting the whole cartilage of the ear. So from a differential diagnosis point, I think it is really helpful. In unclear conditions, I would always perform a histology, because you don't know what's going on. We recently had a patient who had first manifestations of a lymphoma on one ear. And it really looked like relapsing polychondritis. It was severely inflamed, it was really painful, and it was a lymphoma infiltration. So these are uncommon manifestations, but I think always if you are unsure if this is really relapsing polychondritis, I think it might be helpful to do a biopsy. Otherwise, clinical manifestations, if it really fits the image of relapsing polychondritis, you can use the ultrasound probe, because it's really fast and it really makes fun. The CT is not really helpful because the resolution is low. If you use a 3 Tesla MRI, you would probably also see it. With 1.5 Tesla MRI, I think it can be tricky actually to show the chondritis of the ear.
Okay, there's a question on the lab parameters, especially increased ESR and CRP. Is it a systemic inflammation?
Yes, it is systemic inflammation, and I personally find it also really helpful to follow up the patient, to use the very simple and cheap parameter CRP. we do not use the ESR anymore because it just has so many confounders. But CRP in a patient with active disease actually could be, and I would expect raised CRP values in a patient with active disease. And most of those patients who go into remission also normalize with their CRP. And if they do not normalize, it really can be a hint to look for other organ manifestations in order really then to think of intensifying therapy. Yeah.
But would you exclude the relevant polychondritis with normal CRP and normal ESR?
If the patient is not treated, I would not exclude it, but yeah, you know, nothing is 100%. But I would be suspicious if this is really relapsing polychondritis. Yeah.
So the high systemic inflammation is some form of autoinflammation because you have the relapsing cause of the polychondritis, which looks like an autoinflammatory disease, but you have a progressive damage with that disease, which
Yes.
looks a little bit like an autoimmune disease
Yeah.
from the view of imaging and from histology, which is in some part form of imaging.
Yeah.
Do you think it's more autoinflammatory or more progressive autoimmune?
Yes, thanks for that question. It's actually both. So as from a histology level, we see an early infiltration of cells of the innate immune system, monocytes, macrophages. And in a later stage, we even see infiltration of T cells. So I would say it is both. Although the hard question is always of immunologists, well, if it is an autoimmune disease, show me antibodies. Yeah. And there are no antibodies, at least no established antibodies in relapsing polychondritis. So you might question that as well. But it's from a histological point of view, it's actually a combination of both. Yeah.
Okay. So I don't see any new questions. I think it's a wide field to be worked on because we still have no clear recommendations. We still have no experience on imaging in relapsing polychondritis, and
it is really a rare disease, right? So
which we should ask everybody who is interested if he had any experience to publish it to increase the amount of experience on imaging in relapsing polychondritis and perhaps to have in 10 years better data. Do you think artificial intelligence might be helpful to detect this rare disease? Because asking other colleagues, most of them never have seen a patient with relapsing polychondritis, so never seen such a patient. They probably would not diagnose it. And could artificial intelligence help for that, or is it too rare for artificial intelligence?
Artificial intelligence is always great if you have a high amount of data you put in. As this is a rare disease, I think that AI might quite struggle diagnosing it. What could be really great would be something similar as Rashid Lukmani did a couple of years ago with the DCEVA study, where he basically just made an online registry where you could hack in all your patients from all European countries. And then later he derived out of the DCEVA study the new Euler classification criteria, because it was just the largest database available even on rarer diseases like vasculitis. So I think this would be also very helpful if the ERN would suggest such a study, that we actually put all our rare patients into a registry in order to form classification criteria, which also do not exist for relapsing polychondritis. Yeah. I really think it would make sense to have here a combined effort to have a registry and perhaps even a local biobanking of those patients to later also look for different immune cells or even biomarkers for the disease. As with modern proteomics, we have the possibility to show biomarkers which we were not able to detect 5 years ago. Yeah. So this would be a great, I think, a great project.
the preparation of the registers is nearly complete, so they will start soon to be
That's
one
great.
of the projects of the Ehrenreconnect working groups on relapsing polychondritis and on others. There's one question, if you might not, I might answer. It's on anti-cartilage antibodies or anti-cartilage autoantibodies.
I do not know of any published data on that, but this does not mean that they don't exist. I haven't researched the literature concerning this topic extensively. Yeah.
The probability to detect consistently autoantibodies or to use it as a screening tool or a confirmation tool has failed up to now, because they are not consistent and the cohorts are a little bit problematic to confirm it up to now. So I think biobanking will be one of the steps to find it with a better precision. And I think one of the problems of former trials on relapsing polychondritis is the mix-up with the VEXAS patients who had been classified as relapsing polychondritis, but have different disease with secondary polychondritis, as we know now, but they are in the pools of former knowledge and might disturb the image you have from the more autoimmune parts of the disease. Okay. So if there is no further question, we are happy to have all this interesting data on imaging in relapsing polychondritis. We had a very interesting discussion on further fields, and we hope to have more data in future. Thank you for your attention and have a nice day, and perhaps see you on EULA in Barcelona. Thank you, Valentin, for your presentation.
Thank you, Oliver.